This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
The Health Library has asked us this evening to talk about abdominal aortic aneurysm disease. This is an extremely common problem in mature Americans. Incidence of abdominal aortic aneurysm disease is approximately 6% of men and about 1.5% of women over age 55 in this country. In terms of its overall significance, it's in the top 15 leading causes of death of mature adults if aneurysms like the one you see on the screen here are not treated. And actually, recently there's been a lot of interest in abdominal aortic aneurysm disease, including front page articles in the Wall Street Journal, which resulted in the journal receiving a Pulitzer Prize for health reporting 2 years ago, as well as a variety of discussions in Congress this last year about the value of potentially screening for abdominal aortic aneurysm disease. And those are all topics we're going to discuss tonight. So I don't have a pointer, but as you can see on the screen, an aneurysm is an enlargement of the aorta. The aorta is the major blood vessel that brings blood from your heart to all the organs in your body. And the image we see on the screen, the bifurcation of the aorta, where it splits into the two iliac arteries below, is generally at about the level of your belly button. And the upper portion of that aneurysm is up close to the xiphoid sternum at the lowest part of the sternum here. So this is really a problem right in the middle of your abdomen. An aneurysm of this size can easily be appreciated on physical examination, and your physician can find that for you and recommend treatment. A more interesting and challenging situation, actually much more common, are smaller aneurysms, which require a more sophisticated imaging test to identify. So, as I mentioned, who gets aneurysm disease? Well, men and women, generally older adults. There are individuals who get aortic aneurysms, younger age groups, but they tend to have certain types of genetic predispositions towards tissue weakness, such as Marfan syndrome or similar disorders that can cause their blood vessels to enlarge abnormally. For the vast majority of the population that has a normal genetic distribution, this is really an age-related condition, and it occurs more frequently in men than women. There are well-known and well-characterized risk factors for aortic aneurysm disease. Number one is smoking cigarettes. In a large study supported by the Department of Veterans Affairs in the United States, 77,000 men were offered free ultrasound screening for aortic aneurysm disease. Of that 77,000, approximately 4% were found to have aneurysms. And when they looked in a retrospective fashion to what they suspected were the known risk factors for aneurysm disease in this group, the highest risk factor association was cigarette smoking that had a relative risk of 5. The next highest risk factor is if you had a first-degree sibling, brother or sister who had an aortic aneurysm. The risk factor for that was 1.5, and all other known risk factors were less than that. So overall, smoking cigarettes is by far and away the highest risk factor for aortic aneurysm disease, much higher risk in the population in general than family history. This is a smaller aneurysm. You can see in this diagram, this is offered by the Society of Vascular Surgery on one of their educational websites. I'll show you how to find that towards the end of the lecture. And you can see the location of the aorta, the location of the aneurysm, and that aneurysm is much, this is actually an artist's conception of an aneurysm. The prior image is actually a real aneurysm from our own practice. That's after CT scanning and reformatting of the image on CT scanning. But these are the types of aneurysms that are more common, the kind that there's less clear currently treatment recommendations available, and the kind that typically patients will approach us with questions compared to, example, this needs surgery soon, and we'll talk about what kind of surgical options are available for that as well. Interestingly, aortic aneurysm disease is actually a very significant health hazard. If you look at case mortality rates, how many patients actually die from the problem, breast cancer and prostate cancer are more common, but abdominal aortic aneurysm disease is far more lethal than either of those other two conditions. And so on average, interestingly, the case mortality rates for aortic aneurysm disease are similar to that of breast and prostate cancer, responsible for each of those conditions for about 30,000 deaths per year in the United States. So as I mentioned, an aortic aneurysm is a weakness and a progressive enlargement of the aorta below the branches that go to the kidney arteries, above the branches that go to the legs. They grow at a typically predictable rate once they're identified. It varies depending on the study, but trials have been conducted in the United Kingdom, in Australia, and the United States, all trying to identify a specific growth rate. And as you might imagine, an aneurysm of this size probably grows slower than an aneurysm that's larger, but on average they grow 2 to 2.5 centimeters a year. I'm sorry, 0.4 centimeters a year. So it takes about 2 years, 2.5 years for them to grow a centimeter. And if those of you who aren't up on your metric conversions, there's 2.54 centimeters to the inch. The normal diameter of the aorta below the kidney arteries, and the area you see there that's kind of highlighted in the box, should be about 2.5 centimeters, or about 1 inch. If it's 3 centimeters or larger, that's by definition an aneurysm. Currently, we recommend surgical treatment when these aneurysms in this location are 5.5 centimeters or larger. Just for comparison, that's an 8 centimeter aneurysm. Patient didn't know he had until he had a CT scan for another reason. So aneurysms do grow at a rate that will allow potentially for treatment between the time they're first identified and smaller aneurysms and when they're offered surgery for larger aneurysms. Currently, though, there are no clear and well-proven treatment options for these smaller aneurysms. We'll talk a little bit about treatment alternatives for those later. But if you just do the math, there's between 3 and 5.5 centimeters is 2.5 centimeters divided by 4. Approximately 6 years will pass between the time that someone is determined to have an aneurysm at 3 centimeters and when we would typically recommend surgery. That recommendation can change if the aneurysm appears to be growing more rapidly, if the patient has a strong family history of aortic aneurysm disease, or if they experience symptoms which we feel are possibly related to the aneurysm. The appropriate symptoms typically involve either abdominal pain, sometimes confused with back pain. Occasionally, it's not hard to imagine that aneurysms of this shape and configuration may contain some blood clots, which can pass down from the aneurysm into the feet. And occasionally, arteries that are going to the legs, as you see on the bottom of the screen there, can become blocked by the aneurysm process proximally. But when these do become symptomatic, the most common symptom is pain, and that is usually an indication for prompt repair. Aneurysms can rupture at almost any size, but for practical purposes, it's very unlikely that aneurysms rupture until they approach 5 centimeters in diameter, and that's where the current recommendation of treatment at 5.5 centimeters is drawn from, because the idea there is that the risk of the surgical repair is outweighed by the risk of the disease process itself. So although smaller aneurysms can rupture, typically we're confident that if they're growing at a predictable and predicted rate, that we'll manage them until they reach the treatment threshold, which has been determined by a number of these studies, and then we'll offer treatment. Aneurysms are most commonly detected today on the basis of abdominal imaging studies that have been done for other reasons. such as an ultrasound to look at the gallbladder or the kidneys, CT scan to look at the pancreas or the colon or the stomach, or some other study such as a magnetic resonance imaging study that's used to look at the back. Any of those tests will identify quite easily the presence of an abdominal aortic aneurysm, even a small aneurysm, and then those patients are typically referred to us for management. We'll go into treatment in just a minute in a little more detail, but as I mentioned, for aneurysms like that, basically that portion of the aorta has become worn out and needs to be replaced. And we do that in a couple of different ways, which I'll show you in a minute. It may be that there are some treatment options for smaller aneurysms. We'll talk about that. Surgical treatment for advanced aneurysms has been performed in the United States for about 50 years. And the traditional method of treatment involves an incision in the abdomen and basically replacing this enlarged segment of the aorta with a prosthetic graft. The graft material we use most commonly is Dacron, medical grade Dacron, specifically for this purpose. And there are patients who've survived 20 or more years after these procedures, and Dacron has proven to be safe and reliable for this application. There are currently about 50,000 open abdominal aortic aneurysm repairs performed in the United States each year using these techniques. Since 1999, there has become in the United States generally available alternative methods for treating these aneurysms that avoid an incision in the abdomen and allow for quicker patient recovery after the operation. And I'll give you some examples of that in just a minute. So getting back to the idea about aneurysm shape or morphology, you'll see on the screen to my right that just where the aorta breaks into the two arteries that go to the iliac arteries, which go to the leg, the aorta will start to enlarge. Notice, too, that it's actually elongated, that the space where the artery goes off to the kidney on the top and the space where it connects to those iliac arteries at the bottom has become somewhat S-shaped. And that's because as the aorta starts to deteriorate, it loses its elastin, which is a protein present in your body that provides tension in your skin and tension on these aortic major arteries and major blood vessels. And just as you get wrinkles and your skin starts to sag as you get older, you lose elastin. But interestingly, look, you're just losing elastin in one portion of the aorta there. And in fact, this is by far the most common location for arterial aneurysms, although they do occur in other places. But for some reason, this particular area between the kidney arteries and the arteries that go to the leg seems to be most prone to this degeneration. Not only does the aorta enlarge because of a loss of this elastin, but the aorta actually becomes elongated as well. And then frequently these two processes go hand in hand as part of the deterioration. Now the image you see to the left of the aneurysm image, there's been an endograft placed in that aneurysm. And the endograft was the treatment method I was referring to previously that's been available now generally in the United States for about 7 years, which involves actually replacing or placing a covered stent within the aneurysm to rechannel the blood flow into the normal arteries below the aneurysm and excluding the aneurysm from the circulation. There are several acronyms that are used for this type of procedure. The most common is endovascular aneurysm repair, or EVAR, E-V-A-R. And you can see this particular patient is an ideal candidate for this type of procedure because the aorta leading down to the aneurysm is pretty much normal until it reaches a specific area where it's large, and the vessels leading out of it are relatively normal. And that combination of anatomic features makes it more amenable to treatment with this method. Currently in the United States, more than half of all aneurysm repairs are performed using this EVAR technique. And we do a lot of aneurysm surgery here, both open and EVAR. In our own practice, we don't see that many patients like this because a lot of community surgeons have become comfortable with these EVAR procedures, and they'll treat patients like this with this type of an approach, and they tend to send us patients that are less amenable to this type of management, but we still perform over 100 of these procedures a year using this EVAR technique. Are all aneurysms alike? Not at all. Imagine if we took these pictures, this is done with a catheter-based angiogram. You can actually see, if you look carefully inside that aneurysm, you can see a little tube with markers along it. Those are 1 centimeter markers we use for making measurements when we deploy the device. You'll see that running up along the inside of the aneurysm. That same tube allows us to inject contrast, which is a medication which reflects X-rays, and so provides us with an outline of the blood vessel during the contrast injection. That's called an angiogram. The image you see on the top is actually from a CT scan. Some of you may have had that prior. This is actually a procedure where they inject a little contrast in your vein, and then they wait a certain amount of time for it to circulate through the heart and then move out from the heart through aorta, and then it takes multiple slices imaged like a spiral ham situation. Takes 2.5 millimeter slices through the area in question and then reconstructs those images into a single picture like that. So this is a procedure that can be done as an outpatient with relatively minimal risk, except for the contrast injection. Some people are allergic to contrast. But you'll see in this aneurysm, compared to the ones you see here, it's much closer to the arteries that go to the kidneys. It's much more serpiginous, shaped like a snake rather than a straight line. And you'll note that it actually has almost more than a 90-degree angle between the direction it's moving just below the kidney arteries and coming back like that. That, as you might imagine, is much more challenging for placing an EVAR device. And this is a type of an aneurysm which we typically, currently would consider potentially repairing with an open repair, because we can expose the anatomy around this area, open this aneurysm up, sew a graft in place, and take care of the problem that way. As I mentioned, that's a technique which has been really well established and standardized for several decades, and the outcome for those procedures at Stanford Hospital for first-time operations is excellent. And so that are our options, but it's just interesting that this is basically the same disease process as that, but this has obviously been present for a much longer time. It's grown much larger, and as they grow larger, the options for treating them become somewhat more limited. The slide on the bottom is a fascinating study by a German vascular surgeon that was published in the British medical journal Lancet in 1989, looking at almost 500 German World War II amputees. And Dr. Vollmar's clinic had hundreds of these World War II amputee patients, and they noticed that there seemed to be an increased incidence of aortic aneurysms in these patients. So they performed a study comparing German World War II veterans who had not had an amputation versus those who had, matching up the known risk factors such as smoking and family history, and compared several hundred patients in both groups. And they found that the patients who'd had the amputation were 5 times more likely to have an aortic aneurysm 40 years after the amputation than those who had not, and that the shape of the aneurysm seemed to be reproducibly related to which of the 2 legs had had the amputation. And actually, this observation has been a stimulus for much research into how blood flow conditions modify aneurysm risk and aneurysm development. And we have some ongoing research in this area that I'll describe in a little while as well. But this gets to the question, are all aneurysms alike? Some have a convexity to the left side, some have a convexity to the right side, some occur closer to the kidney arteries, some are further away from the kidney arteries, but by and large, they all occur in this area to differing degrees. And exactly how they're related to the arteries, to the kidneys, to the legs, their shape, tortuosity, how irregular they are, makes a big difference in terms of what type of treatment options we can provide. This is another aneurysm we treated emergently in April on the corner of the screen. This patient came to us with, he also actually had aneurysms behind his knees. Patients who have these